getting close to order, people, okay? So you should find your seats. Order. This is the Standing Committee on Health. My name is Suzanne Lonis-Croft. I am the MLA for Lunenburg and also the Vice Chair of this committee. Today we will hear from the College of Dental Hygienists and the Department of Health and Wellness regarding children's oral health. A reminder for everyone to turn your phones off or put them on vibrate. And in case of emergency, please exit through the back door and walk down the hill to Hollis Street and gather in the courtyard of the gallery, the Nova Scotia Art Gallery. I will ask committee members to introduce themselves, beginning with Ms. DiCostanzo.
Good afternoon and welcome. I'm Rafa DiCostanzo, the MLA for Clayton Park West.
Good afternoon. I'm the MLA for Waverley Fall River Beaverbank, filling in for Keith Irving.
Good afternoon, folks. I'm Ben Jessam, and I represent Hammonds Plains Lucasville.
Hi, I'm Margaret Miller. I represent Hants East.
Hi there, my name is Colton LeBlanc, the MLA for Argyle Barrington.
Good afternoon, I'm the MLA for Cole Harbour Eastern Passage, and my name is Barbara Adams.
Hello, I'm Susan LeBlanc, I'm the MLA for Dartmouth North.
Hi, I'm Claudia Chender, MLA for Dartmouth South.
I welcome our witnesses today, and I will ask them to introduce themselves, starting with Ms. Lagassé.
Good afternoon, Jeannine Lagassé. I'm the Acting Deputy Minister of Health and Wellness.
Angela Purcell. I'm the Executive Director of the Pharmaceutical Services and Extended Health Benefits Branch at Department of Health and Wellness.
Hi, I'm Dr. Ferne Kraglund. I'm a public health dentist and I work full-time at the Faculty of Dentistry at Dalhousie University, and I'm also working part-time as a dental consultant with the Department of Health and Wellness.
Good afternoon. My name is Stacy Bryan. I'm the current Registrar for the College of Dental Hygienists of Nova Scotia.
Good afternoon. My name is Patricia Grant and I'm the retired Registrar for the College of Dental Hygienists of Nova Scotia.
Hello, my name is Shauna Hachey. I'm an assistant professor in the School of Dental Hygiene, Faculty of Dentistry at Dalhousie University, and a practicing dental hygienist.
Hello, I'm Dianna Major. I am a dental hygiene practice owner.
Thank you. We will start with our opening remarks, and I will call on Ms. Lagassé for her opening statements.
Thank you, Madam Chair. Good afternoon. I would like to start by thanking the committee for the invitation to appear here today. We are pleased to be here with the representatives of the College of Dental Hygienists of Nova Scotia, one of many partners in improving the oral health of Nova Scotians. Our other partners include the Provincial Dental Board, the Nova Scotia Dental Association, the IWK Health Centre, the Nova Scotia Health Authority, and universities and colleges. Along with dentists, dental hygienists play a vital role in preventing dental disease and helping to maintain good oral health. Many factors impact a person's oral health, including things like access to dental services, eating a well-balanced diet, access to fluoridated water, and good oral hygiene practices. We are here today to speak specifically about children's oral health. We know that dental care and good oral health habits need to start at a young age to achieve the best results. The department develops, implements, and monitors programs that support oral care for our children. Our largest program, the Children's Oral Health Program, provides funding for basic dental care for all children 14 years of age and under. The provincial government also funds 6 other dental programs, each of which meet specific needs of our citizens. Government has been supporting children's oral health services since 1974. The Children's Oral Health Program was created in 1997, replacing the Children's Dental Plan, and has evolved over the years. Recent changes to the Children's Oral Health Program were informed by the collaborative work of the Oral Health Advisory Group. This group had broad engagement with professional and community representatives, including the College of Dental Hygienists, the Nova Scotia Dental Association, Dalhousie Faculty of Dentistry, and department representatives. In January 2019, the Children's Oral Health Program was expanded to include molar sealants and annual fluoride treatment, preventative measures we know lead to improved outcomes. We would also like to highlight the following areas that support our children's oral health. Dr. Ferne Kraglund, who is with us today, is the department's part-time dental consultant who provides advice on oral health to government and offers significant clinical expertise. A fluoride program is offered in 139 schools in communities most at risk for poor oral health outcomes. 14 dental hygienists work in schools through the NSHA's public health program, delivering the fluoride program and working on a variety of matters that affect oral health outcomes, such as school food policy, healthy food environment, and poverty reduction. New agreements between the Department of Health and Wellness and dentists are in place for publicly funded services, including these expanded preventative services. Fluoridated drinking water continues to be provided in most of our major municipalities. While progress has been made, we know there is still more work to do. We will continue to look for opportunities to collaborate with our dental community partners as we consider further changes that will benefit the oral health of children in Nova Scotia. We greatly appreciate the college's work, including the development of its white paper published in October 2014. Since that time, the paper's recommendations have helped to inform our work and changes made to focus more on prevention as a key part of improving oral health. In closing, I would like to acknowledge the work again of the many partners in the dental community that promote the importance of oral health and dental care for our children. In particular, the college, the Provincial Dental Board, the Nova Scotia Dental Association, the IWK, and the NSHA. Thank you.
Thank you. And I'll call on Ms. Bryan for her opening statements.
Good afternoon. We thank you for inviting us here today to continue the conversation about improving children's oral health in Nova Scotia. We're pleased to have here with us today one of our partners, the Department of Health and Wellness, as the second group that will be presenting to you today. The CDHNS and the profession of dental hygiene in general are committed to improving the oral health and overall health of Nova Scotians. We are committed to ensuring equitable access to oral health for all people in this province. We want to be active partners in creating and delivering the solution. We support promoting health and preventing disease by integrating dental hygienists at their full scope into Nova Scotia's primary healthcare system. We strongly believe in preventing more to treat less. It is wonderful that a children's oral health program exists in Nova Scotia, and it is a testament to this government and all governments in the past who recognize the importance of providing a program that focuses on children's oral health. However, despite the fact that we've had a children's oral health program as part of the Medical Insurance Program, or MSI, in Nova Scotia since the 1970s, we know that there is significant room for improvement. We are here today to provide some insights into potential approaches that complement the existing initiatives to ensure that future children's oral health initiatives will be more effective for all children in this province. We recognize that there are many competing needs for the limited resources in this province, and it is critical that we spend our resources in a thoughtful manner to achieve a long-lasting return on investment. While the majority of oral health care services are excluded from our healthcare system, the impact of oral disease is not. Early childhood caries, cavities, or tooth decay is a crisis in Canada, and the same is true in Nova Scotia. Tooth decay, a preventable disease, is the most common chronic disease among children, and treatment of tooth decay is the most common day surgery for children in Canada. Poor oral health in children affects nutrition, growth, sleep, learning, behavior, socialization, and self-esteem, communication, and ultimately can cause failure to thrive during some of the most critical years of child development. There is an increasing body of evidence suggesting linkages between oral disease, both cavities and gum disease, and systemic conditions, including diabetes and cardiovascular disease, which could potentially have lifelong impacts. While the number of beneficiaries through MSI has increased since the age of eligibility increased in 2013, the rate at which the program is being accessed has declined. The 39% who accessed services in 2018-19 is 3% less than those who were accessing MSI when the CDHNS prepared the white paper in 2014. Why is this so? Of the 61% who are not accessing the program, it is likely the majority belong to the populations most at risk for oral disease, including children who are living in families with lower socioeconomic status, from Indigenous populations, those living in rural communities, or newly immigrated to Canada. Every child has a right to live without the burden of oral disease and all its negative impacts. Our white paper envisioned a healthier future and included 13 recommendations which made up the basis for a multi-pronged approach to solving this crisis. We still support them all. Some of these recommendations were broad and all-encompassing, while others were specific and directed to certain at-risk population groups, such as children and seniors. Some high-level recommendations included appointing a chief oral health officer, integrating oral health care into overall health, and developing and implementing an oral health strategy that complements the provincial oral health plan. Some more specific recommendations included investing in workforce innovations that integrate dental hygienists into non-dental community-based settings, such as immunization clinics, and mandatory oral health care screenings for children as early as possible. The time was right in 2014, and the time is right now to act on these recommendations. Thank you.
Thank you, Ms. Bryan. We will start our questions, and we'll begin with the PC Caucus for 20 minutes. Ms. Adams.
Thank you very much, and I really appreciate your comments that you both prepared and gave us copies for, so I'm going to reference them to start with. So I'd like to start with Jeannine Lagassé. In your statement, you mentioned that Dr. Kraglund is the department's part-time dental consultant who provides advice on oral health to government and offers significant clinical expertise. And then Stacy Bryan mentioned about the need for a chief dental officer. Now, both the NDP and the PC party in the last year ourselves introduced legislation to have a chief dental officer. So I'd like to ask Jeannine how you feel about this province having a chief dental officer for the program, for the province of Nova Scotia, and how important that might be.
Ms. Lagassé.
As you drawed from my opening statement, Dr. Kraglund started earlier with us this year in 2019 as the dental consultant. It was determined that that was the first step that we would be taking along this path as we look toward preparation of a more comprehensive oral health strategy. And so Dr. Kraglund is currently on contract with us until the end of March, and we are going to be issuing a request for proposals for a longer-term dental consultant once that term is up.
Ms. Adams.
Thank you. Is there consideration to expanding that from part-time to full-time?
Ms. Lagassé.
At this time, the consideration is that it would remain part-time.
Ms. Adams.
Is the Department of Health and Wellness considering implementing a chief dental officer for the province?
Ms. Lagassé.
At this time, the department will be continuing with the dental consultant as we move forward with preparations for an oral health strategy.
Ms. Adams.
Can I ask, we don't have representation from the Department of Dentistry or the Dental Association. So does the Dental Association itself also support the recommendation for a chief dental officer?
That's for who? The Dental Association. Oh, who wants to take that? Okay, Ms. Purcell.
So I think you'd probably have to speak to the Nova Scotia Dental Association to confirm. I know they were pleased that we did hire a part-time dental consultant as a step in the right direction. That's about all I can say on their behalf, given our past conversations.
Ms. Adams.
Okay, so we don't know how the dentists in the province feel about a chief dental officer, but I would assume that they would likely be in favor of it. I think it would be good to know what their position is on it, and I would be interested in knowing why it wouldn't be a good step, why we wouldn't move towards that, given the magnitude of the expense of dental care in the province. I'm wondering if the Department of Health and Wellness can tell me we know what the cost for pediatric dental care is in the province, according to the stats we were given, was $6.1 million in 2018-19. What's the total budget for dental care in the province?
And that's?
Whoever can answer.
Okay, Ms. Purcell.
So we, last fiscal year, I think it was just a little bit over $10 million that we spent on all of our dental programs. I'll just put a reminder out that we have what we spend on those dental programs. We don't have a figure for what private drug plan, private dental coverage is and what that expense is. So it provides the government cost for this, but not the private share of that cost.
Ms. Adams.
Thank you. So when we look at the statistics that we were given about children's dental services in Nova Scotia from 2008 to 2019, in 2015-16, it shows that the number of services rendered was 273,147. And then it drops considerably the next year. And then in 2018-19, the last year we have numbers for is 173,825. That's a dramatic drop of almost 8,000 services rendered, so almost a third fewer services rendered. Can somebody explain to me why we have a third fewer services rendered, as was mentioned during Stacy Bryan's comment that the number of services has gone down in the province?
Who would like to take that? Who? Ms. Lagassé.
So we don't know with certainty, but because the program is payer of last resort, a number of people do access dental services through their private insurance. So the drop may in fact be that people are accessing dental services, but it's being paid for by private insurance.
Ms. Adams.
Okay, so then I guess what I'd also like to understand is, can you describe to me what the wait time is like for children to go to the IWK for a consult with a specialist, and then the wait time for actual surgery if the child needs surgery?
Ms. Lagassé.
I'm sorry, we don't have that wait time with us. We can provide that to you, though. We could consult with the IWK to get that.
Ms. Adams.
So on the website for the Nova Scotia government, I have the wait times themselves. And right at the moment, the consult for children is 293 days just for a consult. For an actual surgery, it's another 378 days for a total of an average of 563 days from the time you are referred to the time you actually have your surgery. And I see the dental hygienist nodding, they know. That's a year and a half exactly. For adults, it's 464 days, so it's actually 100 days shorter for adults. So if we assume that the number of services got cut by almost 100,000 and maybe people are getting it through private, why do we have a year and a half wait time for children to go to the IWK for specialized services?
Ms. Purcell.
So I can speak a little bit to the dental academic funding plan and the program we provide at the IWK. I think it is recognized by all partners that there's been wait times for surgeries and for specialized care for children. A couple of years ago, government invested in another dental specialist for that AFP, as well as the anesthesiology support to help deliver those services. It took a while to recruit that provider, as you can appreciate. And since that provider has come on board, they have also made great efforts at trying to address some of those issues. So they recognize that perhaps the wait times are longer than they would ideally hope for, and they have started to look at some lean processes, so some process improvement to make sure that the referrals that are coming in from community-based dentists are actually the specialized care is needed at the IWK for instances where that care could be provided by a community dentist. They are also transitioning those back to a community dentist. So work is underway. I appreciate that probably the volume and the wait time is not where we want to be, but I think collaboratively with the partners, efforts are being made to try and address that.
Ms. Adams.
Thank you for that. So according to another stat that we were given, over 500 children are currently waiting to get into the IWK, according to this. And, oh, sorry, I'm not sure if that's the exact number now. Can you tell me if the number of kids waiting and the wait time has improved or declined over the last 5 years?
Ms. Purcell.
I'd be happy to reach out to confirm. I believe it stayed about stable. Up until now, it hasn't either increased or decreased significantly. But again, I'd just like to highlight that that additional resource took some time to hire, and there have also been some additional circumstances in terms of access to anesthesiology across the province that has resulted in more care being centralized in Halifax, and so there's a shift across the province that is happening at the same time that could impact that.
Ms. Adams.
Okay, so I appreciate that. If you look at the wait times, though, for dental extraction and restoration consult and surgery, in Halifax, it has the highest wait times of 370 days for a consult to 441 days for surgery, for a total of 811. Whereas somewhere in Amherst, it's 112 days for a consult and 50 days for surgery. So I'm assuming it's because the IWK is a specialized area that wait time is there. The dentists that we've spoken to suggest that the wait times are actually getting longer. And one of the things that we also got in those statistics is that the number between 2008 to 2019, the number of services per insured person went from 2 insured services per person in 2008 to 1.8 during the NDP government, to 1.7 at the beginning of the Liberal reign, and it's now at its lowest point to 1.3. And yet the amount of money we're spending for dental care for children, when we were offering in 2015 273,000 services, it cost us $6.8 million. We dropped almost 100,000 services and it cost us $6.1 million. So I'm wondering from the Department of Health and Wellness, how have we offered 100,000, almost 100,000 less services, but the amount of money we've paid out has only dropped 700,000? And I have the numbers here if that's helpful.
Lagassé, is that? Or
Sorry.
Ms. Purcell?
Okay, I'll try and respond to that. I may not have all the answers. And I think one of the challenges, and just to go back to it, is we have a piece of the information. So we know what's happening in the programs that we fund. We don't know what's happening when you align this with private drug coverage. So I have the same information that you have in front of you. I think when the age increased, I believe it was at the initial period of this 2013, 2014, it's not uncommon when there's a change in a program that following year, there's been some communication about that. And so sometimes you will see an increase in utilization that will then historically kind of taper out. That could be one reason. The private coverage could be another reason. All things combined, I think what I'd like to emphasize is the program is available to all children. It's not a capped budget. It's not something that we say, has a fixed dollar amount, so it is based on utilization. And so utilization, as it does across many of our programs, fluctuates from year to year, and the factors that play into that are numerous.
Ms. Adams.
Okay, I'm a little confused though, because that trend that I referenced has been going on for several years. It's not a one-year change in the drop. So although I know it's not a capped program, but the end result is that there are fewer services being offered per person or being utilized per person now compared to 10 years ago. And yet the budget amount did not drop significantly. One of the things that I'm aware of is that in Nova Scotia, there's legislation that blocks dentists from extra billing when the fee code that MSI puts in place doesn't match what the Dental Association's recommendation is for that particular service. And some of the dentists have indicated that when this government changed who was covered, they did it without consulting the dentist. They found out about it at the same time as everybody else did, or a couple of days sooner. And what is in fact happening is that there are some procedures that dentists are doing at a loss of income. They're actually losing money by providing some of those services. And so their reaction, as they've told me, is that there are some who are making the decision that it's not cost effective now to provide pediatric dental care. And I'm wondering if you're also hearing that and if it's a concern to you, because it is for me.
Ms. Purcell?
Yeah. So appreciating the change that happened in 2013, 2014, perhaps was not well known to the dental community before it was announced. Government then initiated, as you might be aware, a review of the Children's Oral Health Program. So put the changes to that age at a stop while the program was reviewed. So I am aware that the dental community was not happy with that. Other partners were not either. A review was done, and the results of that review said to keep the age at 14, which is what it has stayed at. And so we've worked closely with them since that time to review all of the programs and to implement a new contract. So we have a new agreement with the NSDA that's about a year old that has some new preventative services in that to help address really the recommendations from a number of partners that have helped to inform the work forward. Are we where we need to be? Maybe not, but I have certainly through our discussions with the NSDA and the Dental Association feel we are better than where we were.
Ms. Adams.
I'm assuming that might be over the past year, perhaps, because I know in 2013, when the contract was signed, the dentist said that they were not consulted. And in 2017, when the changes were made again, they got this very brief notice before those changes were made in terms of the fee codes. And I know when there was an announcement made about cutting out scaling and cleanings, the dentists were not aware of that. So they're not feeling consulted, at least the ones that I'm speaking with. So it goes back to having a chief dental officer rather than a chief medical officer being the one responsible for this. So we're going to continue to encourage the Department of Health and Wellness to consider implementing the chief dental officer, who would have a better understanding of all of the players in this game and not just one certain part over another. I do want to go back to the surgery wait times, where the statistics are showing that there were fewer services rendered by the public system. Does the Department of Health and Wellness make any attempt to find out how many of those services are being offered by private providers? Because if you're going to look at implementing other programs, like a school dental program or any other program, you'd need to have some idea as to how many people are actually getting dental care before you assume what kind of a strategy might actually improve dental care. Because if in fact fewer people are going to the dentist, that's one thing. But if more people are going to the dentist and therefore are getting fewer services, that's a different strategy. So has the Department of Health and Wellness or any of the associations reached out to the private insurers to get statistics from them as to how much private dental coverage there is in the province?
Ms. Lagassé?
At present, we have not reached out for that information, but I would expect that as we moved forward in preparation of an oral health strategy, that's the type of information that we would be looking to gather.
Ms. Adams?
Does the Department of Health and Wellness have feedback from the Dentistry Association on the 13 recommendations that the Dental Hygienists Association has made? Have they given a formal written response to what their feelings are about all of those 13 recommendations?
Ms. Lagassé?
Not that we're aware of kind of formal written response. However, the Dental Association were partners with us and others in the oral health advisory group, so they would have been aware of all of the information that was before us at that time.
Ms. Adams?
So I appreciate them being aware of the information and the recommendations that may have come out of it, but I think it would be useful to consult with them in a formal way to say these are recommendations made by another allied health professional in the same industry. You know, how does your association feel about that? I think that's important because, you know, they're the ones who are ultimately responsible for they're the family dentist. And so I think it's important that they have feedback on this. And I think it would have been good for us to have had them here so that they could give their feedback on why those wait times have gone up. Because a 1.5 year wait time, I have 4 children. If any one of them had to wait a 1.5 years to have a dental extraction, it'd have been a miserable 1.5 years. So I think it's really important that we have them involved in what we're looking for. I'd like to speak to the dental hygienists themselves, though. And in terms of the recommendations for actions, which of them would you say to you would be the most important for government to look at and to implement?
Who would like to take that? Okay, Ms. Bryan, and you have about 30 seconds.
So one thing I would like to comment on is that when I'm hearing the conversation, I think one thing we are really missing is that we have a whole healthcare provider sector that is being missed. The dental hygienists, we have over 745, and we can actually own and operate independent dental hygiene practices. And we would like to be part of the conversation, which we appreciate today. We'd also like to be part of the solution. There are many areas where we
Order.
look to...
Time has lapsed for the PC caucus. We will move to the NDP for 20 minutes. Ms. LeBlanc.
Well, thank you very much for your opening comments. I come to this meeting as one who went 7 years without seeing a dentist at one time because I have never had dental coverage in my professional life. That's a long time. Thank God I didn't have any cavities when I went back, but that was because I had excellent care when I was young, and there was a dental hygienist who came to my elementary school every single year and worked on every kid's teeth, and that set the stage for my oral health. I also come as a mother of a child who went through a terrible 2018, rife with dental extractions at the IWK. And so I feel really passionately about this subject, and I'm excited to talk about it. So my first comments I just wanted to direct to the department. According to the WHO, oral health care is an integral component of universal accessible primary health care. There was a study published this year in the Journal of Family Medicine and Primary Care, which in the author's words found the integration of oral health into primary care as, quote, the key to affordable and accessible oral health care. We know, as it's been mentioned already today, that that oral health care is directly connected with overall health care. Gum disease is linked to heart disease, diabetes, respiratory disease, osteoporosis, rheumatoid arthritis. And on top of the physical issues, poor oral health care is also predictive of poor mental health care, and people who suffer from severe mental illnesses are nearly 3 times as likely as the average person to lose all of their teeth. So, given all of that information that we all know in this room, I'm wondering if someone from the department can take a crack at this question. Given that oral health care is so important to overall health care, how come we don't treat it like that in Nova Scotia?
Who would like to take that? Oh, Dr. Kraglund?
So you're right, it isn't seen as part of overall health, and that's been a struggle of our profession for a long time to be included as overall health. It's part of a topic that's greater than a provincial or territorial sort of thing. I've been working with a working group at the Canadian Dental Association who is talking about this, and so it's a bigger issue than a provincial or territorial. It's been left to the provinces and territories to find out solutions, but really it's a national issue that we need to figure out. So there is push at the national level, and it is coming from, specifically, I can't speak for you guys, but from the CDA, from the Canadian Dental Association, that there is a huge push to start putting at least some backup plans to be able to provide some care for people that have infections and such, because it is impacting so many other systemic conditions that they have, and so it is a really important part. So I think as we move forward, we'll start seeing this kind of draw out into a more of a national debate that will then kind of infiltrate more into a provincial and territorial sort of thing.
Thank you. Ms. LeBlanc.
Thank you. And just a bit of a B part to that question. In my office, I see an awful lot of people who are connected with the Department of Community Services, and many times I've had folks come in who need dental care. The department covers, there's like these, there's like these, the Green Shield insurance, and the department covers a certain amount of money, but very often doesn't cover enough of the cost of dental care for folks. I'm wondering if the Department of Health and Wellness works with the Department of Community Services on those metrics, I guess, and if you Ms. Lagassé, you mentioned a new agreement with public service providers, so I don't know if that's what you were talking about, but if anyone could talk a little bit about if there were any changes to make oral health care more accessible for folks on community services or connected with community services. Is that something that you folks work with that department, or is it totally separate?
Ms. Lagassé?
The programs are currently administered separately. So that is, that we have the Children's Oral Health Program and the other ones that we have, and then the DCS one is administered separately.
Ms. LeBlanc.
Thank you. So we know that dental extractions account for 33% of all pediatric day surgeries at the IWK. We know that that proportion could be reduced if we were investing more heavily in prevention, obviously. In 2009, amendments were made to the Dental Hygienists Act that allowed dental hygienists to work without requiring patients to be examined by a dentist first. This change was made in order to increase access to preventative oral health care, but that work is incomplete because dental hygienists are not approved, they're not approved health providers that can bill the province unless they're working directly under the supervision of a dentist. So given the fact that we know that dental hygienists can be such an important part of the preventative side of dental health care, oral health care, why hasn't the department taken the steps to expand the profession under the Health Services Act? It seems to me that that hygienists right now are an underutilized resource.
Ms. Lagassé.
So as we have spoken about a bit earlier, that the Oral Health Advisory Group has completed 2 phases to date. So the first phase was the review of the Children's Oral Health Program, and then the changes that were implemented in 2019 ultimately from that review. And then phase 2 of the Oral Health Advisory Group was a review of all of our other programs that we administer through the Department of Health and Wellness. So as we move forward from that, I think that the next step is for us to work with Dr. Kraglund as our dental consultant on a timeline for the preparation of an overall oral health strategy. We have not done any work to date in relation to any health professionals that would have an input into oral health care, and that review would take place as part of the preparation of a strategy.
Ms. LeBlanc.
Thanks. And so what is the timeline for that strategy? So you've brought Dr. Kraglund in, and when do you expect to be able to table a new strategy?
Ms. Lagassé.
We don't have a timeline for tabling. We're just doing early work with Dr. Kraglund. She started with us earlier this year, and we're just working on kind of timeline for preparation of the strategy. We're in very early stages of it.
Ms. LeBlanc.
Okay, so I just want to be clear about this, so now, right now, we're in kind of a holding pattern, status quo, and the people of Nova Scotia will not see any changes until a strategy is developed and then completed and then implemented. So we could be talking about several years.
Ms. Lagassé. Ms. Lagassé.
That is our current plan, to move towards the implementation of a strategy, yes.
Ms. LeBlanc.
Thank you. So I guess I'm going to direct that same question about the billing situation to the dental hygienist as well. But I also want to, so feel free to address that in your answer to my question, which is, what changes do you feel are needed in order for dental hygienists to provide the full scope of oral health care in Nova Scotia?
Ms. Grant.
Thank you. I think the overall answer to that would be probably still more prevention and less treatment. If I think back to 5 years ago when the white paper was written, we could have an oral health strategy here today with us. So we need to move at both the higher level. Some of our recommendations were very much at the high level, and many of them were very direct and specific about where dental hygienists could be used to their full scope. So I feel like the sooner we begin phase 3 of the Oral Health Advisory Committee work, which was to develop that oral strategy, and I think in all due respect to our friends at the Health Department, we really need to consider that a part-time person who is working in that position, it's a big job to develop a provincial oral health strategy. I'm not sure that it can be done in any time of a timeline with someone who's working on it part-time, and we really need to make sure that we include all of the appropriate people at the table as we move forward with that, and I'm hoping it will be sooner rather than later. I'm sorry, was there another part?
Ms. LeBlanc?
Yeah, it was about the fact that dental hygienists right now can't bill the province for professional services unless they're working under the direct supervision of a dentist. So if you want to speak to that.
Ms. Grant.
Okay. I can't speak to that directly. I'm not, I do not own an independent dental hygiene practice, but we have seen the numbers in the college who register as an independent practitioner rise over the last 10 years since it's been a possibility after our legislation was passed. So we had 5 or 6 who worked in long-term care, and then we have now 18 who register as being independent practitioners. Each of them over my 9-10 years at the college, submitted to me many circumstances where, because they cannot bill MSI, they cannot treat children who were in need. I don't think that's correct for the patient in a situation they're not being able to choose the provider, and I don't think it's correct for healthcare provider who provides the same service in another setting where they would be paid or acknowledged for their work, they aren't acknowledged in a setting that's legal to them. So we do have an independent practitioner here with us today who can provide you with some of those specific stories, and it's probably better to maybe look at that. But there are many circumstances where hygienists could provide care where there just is not another oral health provider available who's able to or can in those circumstances.
Ms. LeBlanc.
Well, sure. I'm sorry, I don't have my name list, but if you would like to chime in, feel free, please.
Ms. Major.
Pardon me. So we do have a dental hygienist right now who is working within the North End Community Health Center. This is a dental clinic that has employed this hygienist to help reduce the burden of disease within their catchment area. This organization has a very innovative structure that includes provision of care to this community through their employed dental hygienist, volunteer dentists, and students. The North End Community Health Center is facing barriers with regards to provision of care for individuals in need and potential reimbursement for services that could be readily provided by the dental hygienist. For example, according to MSI, professional services provided to a client may be claimed by the dentist or claimed by a dentist only when the dentist personally renders or supervises the service. If the dental hygienist does not have a volunteer dentist on site that day, the dental hygienist is unable to bill for treatment for provision of care to children that would qualify under the COHIP program. This causes difficult challenges for the North End Community Health Center as they seek to ensure that they are a sustainable dental clinic. Parents are not fully aware of the MSI program and what it covers, and have heard stories of other families that went to a clinic thinking services would be fully covered, only to find out that they had to pay at the end of the appointment for something that MSI doesn't cover. Often they are embarrassed to decline the 6-month dental hygiene visit that was recommended and won't be covered by MSI, so they book the appointment but don't bring their child to it and subsequently aren't contacted to rebook at the 1-year interval, which MSI does cover. So who is this hygienist seeing? It's this simple. She sees kids who are in pain. She sees 5- and 6-year-olds who have been sent to the IWK for sedation, for extractions, or a full set of stainless steel crowns. And she can see 12- and 15-year-olds that need to have permanent teeth extracted, forever impacting their nutrition, their self-esteem, and their well-being.
Ms. LeBlanc.
Great, thank you very much. Yeah, I just want to jump on something you just said there real quickly, and that is the surprise at the end of the visit where something you think is covered is not covered. So in my great year of guiding my daughter through her several extractions, I came to realize that, or understand that MSI, as the payer of last resort, covers the extractions for children, but does not cover the sedation for children. And when I think about, I did have coverage, and so and obviously I was lucky enough that I'm able to afford $100 a shot for sedation, but many people aren't, and I can't imagine having, as a parent with not a lot of income, to have to make the decision to have my children's teeth extracted without sedation. So why is that not covered? It seems like they have to be part and parcel, those two things. Can someone from the department talk about that?
Ms. Purcell?
So there are a large number of B codes in the dentist guide. I'm happy to take that away and look at it a little bit more closely because I don't know that I have an answer for that today. And I think it's a great question. I think sometimes because of the way healthcare has been set up, we tend to cover things, and as you know, the Canada Health Act covers things that are hospital-based. And so if that procedure is done in the hospital, it would typically be covered under the Canada Health Act and under our programs there. I'm not sure if the same transpires into an office setting, so it may depend on where that takes place, but it's certainly something I'm happy to take away and find out some detail on and have some further conversation.
Ms. LeBlanc.
That would be great, because I do think that, you know, I just think about the folks who would be faced with that decision, and it doesn't make any sense to me. Going back to the dental hygienists, so you spoke a little bit about, you know, sort of roles of hygienists, but could you talk a little bit about how you see the role of a dental hygienist in non-dental community settings? So how the North End Clinic is you know, a healthcare setting at least, but talking about places like long-term care facilities or schools.
Ms. Grant?
Sorry. Yes, I'd be happy to. In the white paper, we recognized that there are many examples, both in the U.S. and a few in Canadian provinces, where dental hygienists were working in community settings that we really needed to be in here. Along came the idea of the first dental visit by the first birthday, and or 6 months after the eruption of the first tooth. But we were thinking about where would we find those children that young. They're not bringing them to the dental office. When they do, we know there is a history of dental offices not being ready to receive them. And that's for a few reasons, I believe. So we thought, you know, dental hygienists should really be, or someone should be really meeting them out in the community where they are. And where would they be? Well, they might be in daycare centers that have government subsidy positions in them. They certainly will be in the pre-primary programs. And we're hoping, we did have a setup, the College of Dental Hygienists had a proposal put forth and a pilot project which we were willing to fund and had received some funding from the Sparkle Fund, which is administered here in Halifax by the Children's Aid Society. So we had some, but the rapid changes that happened in the pre-primary programs, where they were setting new programs up very quickly over that summer, we didn't get to go there, and we hope that perhaps something could be set up in the future for that. So there's lots of places for hygienists to be working. So we have the primary programs, pre-primary, diabetic education clinics, both for adults and for children. There's a higher rate of diabetes among our young people now. Cancer care and rehab centers, registered daycares, early childhood education centers, and schools. The Chief Dental Officer of Canada recognized in quite some number of years ago now, that the best place to present blanket coverage is in schools. You have a captive audience, the children are there, and permission forms go back and forth all of the time. So if you want to do fluoride mouth rinse programs, fluoride varnish, and sealant programs, the plan is carefully laid out for those three things. Water fluoridation is the other issue, and it was mentioned earlier by our colleagues here. So I think those are the areas, certainly seniors and long-term care facilities. There is a great need in those, and hygienists can work, and many hygienists do. They either do it independently or they're doing it as an adjunct of their dental office work. But again, seniors don't all have coverage. You will find many of us, when we leave our jobs, even if we had coverage for a good number of years, we do not in retirement. And so that is an issue for those people as well.
Oh, okay. Ms. Bryan.
Thank you very much. I just wanted to add just one thing to that. As we're talking about children, whether it's primary and on, one of the things that we've come to really emphasize, and Pat alluded to this, is that it's important that we need to do it even sooner, because by the time we are seeing them at 4 and 5, it is often too late for those areas. So some of the other things that she mentioned, the immunization clinics, some of those other potentials may be that where new ways that we can work with the collaborative care
Time
centers.
has lapsed for the NDP. We'll move on to the Liberal Caucus with Ms. Costanzo, 20 minutes.
Thank you, Madam Chair, and thank you for all the information that I've heard so far. It's amazing. really wanted to start by saying that I was hoping that somebody from the IWK would be here today, because I worked with them for many, many years, and I was a medical interpreter, and it was one of my favorite departments to work with. It was the IWK dental department. Unfortunately, they're in the basement in a little hole, but I think you guys have one of the best teams in the world. They are the most caring, hardworking team, and I would go in with a lot of the refugees who have not had any dental care for 3 years, some of them none whatsoever, and the amount of care that they received and the treatment education. And they would allow me to educate them about eating and flossing and using toothbrush, which they've never used. So all this could be done, I guess, at the doctor. So a lot of times, sometimes is used at the IWK where it can be done somewhere else. But I also know that a lot of the cases arrived at the IWK because a lot of dentists didn't want to do the work. So they send to, or they feel uncomfortable maybe with some of the pediatric and dealing with children. Dealing with children is very difficult to even open their mouth. Sometimes it takes 20 minutes to get the child to open their mouth and listen to the doctor. So I think maybe sometimes that is too time consuming for the dentist, and if there's an issue that they feel there's an abscess or this, then let's just send it to IWK. They know how to deal with it. I'm not sure how much of that, but really what my question is here that I heard today, 61% are not using it, our children. That to me is a high number when it's free. So I know that also when I worked in newborns, I would be amazed that they will teach them, use a wet cloth to wipe. I mean, at birth, we're cleaning teeth. This is amazing how good we are with cleaning teeth in Canada. Compared to other countries, we care about teeth, and we do very well. I've lived in England, I've lived in the Middle East, I've lived in Italy. No one looks after teeth as well as Canadians do. And we're very good with hygiene and education, and we should continue with that. And I'm sure there's always gaps, but we have to give credit where credit is due. Canadians do very well with hygiene in general, and if I'm wrong, please correct me. But my question to the doctor maybe here is, when the mothers go home, we tell them, come back for the immunization at 3 months, see your doctor at this so many months and this. Why don't we allow them to say, when is the best time for children to start going to see a dentist or a hygienist? And why don't we start it at birth, send the mother saying at this month, or 6 months or a year, you should be seeing, because a lot of mothers don't know it's available. And that is free of charge. I did not know until my dentist told me, bring your daughter, she's 3 years old, she should have been seen. I had no clue that it was included and covered. So if you can maybe speak to how are we promoting it as well. Thank you.
Dr. Kraglund.
So I can speak to that too. I do work full-time at the Faculty of Dentistry, so I don't work with the pedo department, but I do teach public health and prevention, so I do work with them a lot. So the dental students, I can say at our faculty anyway, are taught that you should start speaking to the parents before the baby's even born. So it's even before birth. So I teach my students, as soon as you know that you have a patient that's pregnant, and you should know that because we check medical history, then that's when the conversation starts. And we find that moms are really receptive to that sort of information, particularly if it's a new mom, because they're receptive to any sort of information at that point in time. But it's getting used to having people communicate that regularly. I find newer dentists might do that a little bit easier than dentists that maybe they've been practicing for decades, where that may not have been habit, where that may not have been the training that they've been doing. And sometimes it may be difficult to get changes of habits when they go into practice. So sometimes it might be the policy of the office that they get into that they don't see by a certain age, but they certainly are trained to be able to see them at, as I said, from beginning age. So within 6 months of the eruption of the first tooth, no later than 1 year of age is what we train. Whether it gets done, that's another thing completely. And so there is a problem with trying to get that information out. So it's definitely something we can work on more in communicating, not only to our dental community, but also to the parents.
Ms. DiCostanzo.
So do you have any statistics of how many kids are going? So right now at school is probably the first point if their family dentist didn't warn the mother to bring them. So the first point is happening when? At age 4, at age 5, as my colleague mentioned. What is happening in the school?
Dr. Kraglund?
So I can only speak anecdotally, so it does depend on the office. So you do hear of some offices that say 3 years old, and it tends to be because of cooperation. But you do have other offices where I worked at the faculty, and even when I worked in New Brunswick, that, as I said, I had that conversation right from the get-go. So there are some dentists' office that the hygienists and the dentists are speaking to moms and dads long before the baby's even born. So it's dependent on what the office kind of protocol and policy is or how they're trained. I wouldn't say it's overall kind of the uptake's not there as well as it should be. It should definitely be more of a policy protocol that that's just what's done. It might take some time to get switched over just because this is a newer sort of thing we've seen in the last decade or so, that this is the training that's been provided to the students, that's what they should be doing.
Ms. DiCostanzo.
Thank you. And maybe you can enlighten us and to know how many of the dentists in general, how many we have and how many actually practice pediatrics, or do they need to have pediatric specialty to practice on children in the private sector? How does it work? Does any dentist can do children and know how to work with children?
Dr. Kraglund?
Yeah, everybody gets training in all disciplines, so pediatrics is one of the disciplines or one of the specialties that we train upon. So anyone can see general cases of, and that's part of a normal family practice of having a general dentistry practice, is that you rely on seeing patients across the whole family, including children. It's when the cases become a little bit more difficult where it wouldn't be suitable to treat the child in office because you feel that there might be some harm to the child, either mentally or physically, just because it could be harmful to them, where you do rely on your specialists to be able to provide that expanded care to them so that it can be done in a safe way. And we rely on all specialists when we have cases that are a little bit more challenging or difficult.
Ms. DiCostanzo.
Thank you. And just in the same line, for anesthesia, what do they have in offices? Because it's one thing to give an adult a needle, but try and give a needle to a child, it doesn't happen. What other methods of anesthesia can they use for children in regular private offices?
Dr. Kraglund?
Yeah, so some of it's behavioral training. So sometimes it's just about talking with the child and trying to get through the trust relationship built. So when I can only speak for myself, but you could get a lot of work done with some children that you could provide any spectrum of care that you would provide to an adult. And it depended on the child and their relationship with the dentist and hygienist of what you could achieve. Sometimes it depended on medical compromised children as well, that you wouldn't feel comfortable doing that. Or sometimes behaviorally as well, you would just want to send that to a specialist. So a lot of cases could be done just with local anesthesia, so what you would normally expect to have when you get a filling or extraction. If it became a little bit more challenging, then you could offer mainly nitrous oxide would be another thing that we would tend to offer. And so people do expanded training beyond dental school to be able to do that sort of training and to provide it to their clients. And as well, sometimes people will do oral sedation as well. So it's a variety of different things that they need to expand their skill set in order to provide that service.
Ms. DiCostanzo.
So am I understanding, we don't have a specialty of pediatric dentists? Everybody is trained in pediatrics, or do we have referrals to pediatric? I'm trying to think what's the percentage of private dental offices that take children? That's where I'm trying to head.
Dr. Kraglund?
So every dentist or dental student going through would be trained to do pediatrics. It doesn't necessarily mean that they'd be trained to do specialized cases. So we do have the specialty on top of having general dentists. So just like any specialty where we might have people that would do certain kind of extractions for adults, some extractions might be too difficult, so you'd want to send that to a surgeon. So same thing with pediatrics is that they would do a certain scope where they would feel comfortable practicing with that, and then cases beyond that scope of comfortability, they would then want to send that off to a private practice where that's specialized in pediatrics. How many cases get sent there? I couldn't tell you. I have no idea.
Ms. DiCostanzo.
I just wanted to know also, where are we as a province compared to the rest of Canada? How well are we doing? I know our numbers have come down. I know that some of the information that I received, the percentage of children with at least one decayed tooth decreased from 74% to 24% between the 70s to 2009. That's amazing. That's a large number. And if you can speak to that, what have we done to reach those numbers?
Dr. Kraglund?
So I have to say, honestly, our data for oral health status in Canada is poor. We had one cycle that was done with the Canadian Health Measure Survey, and it was a cycle done back in 2007 to 2009. We're still using that data as kind of current data, unfortunately. I'm happy to say that we will be participating in cycle 7, which will be coming up next year, so we'll have updated data. That data provided some information to tell us that overall, the oral health of all Canadians, pediatric population included with that, has improved significantly over the last 40 years. What is not included in that is that there are certain populations, certain marginalized populations that experience a burden of illness. So while overall population is improving, there are certain populations that they're experiencing more disease prevalence.
Ms. DiCostanzo.
And I'm assuming you're referring to the rural areas, the indigenous, and the newcomers, when you say certain populations? Yeah. Correct. And what are you doing to reach those? How are you communicating, for example, with the newcomers about hygiene and others? If you can explain on that as well.
Dr. Kraglund?
So I think that's what we've been referring to with an oral health strategy, is that with oral diseases, they are very much multifactorial, so a one type of approach is not going to work. So we do really rely on a variety of different factors and a lot of different treatment modalities, and I don't just mean treatment of providing, treatment in the mouth that we need to apply. So there are a lot of preventive things that we need to do, such as water fluoridation advocacy, providing fluoride month programs in schools and that sort of thing, working with partners to have policies in place that we can provide care at earlier stages, healthy food policies, food security. But all with that, then that's when we can see where we can reach those populations who are not achieving the care. And part of that as well is being able to provide the access to care so that they can get services when they require it. So even when the prevention side doesn't work, that we still provide the provision of care when they have acute problems. So looking at that, the overall strategy is where we're going to be able to come up with those ideas of finding out who are the populations that are not achieving, optimal oral health, and how do we achieve better optimal oral health for those populations through different strategies that aren't currently working.
Ms. DiCostanzo.
That are not working right now, right? Is that what you said? But we have people working on that to improve it. Is that what you said?
Dr. Kraglund.
Sorry.
So that would be a part of what the overall oral health strategy would be, is to looking at what resources that we have. We're also looking at redundancies in services, is that meaning we're all kind of working in silos, but we need to collaborate and pool resources a little bit better to be able to provide better services and to provide better information so that we can get better health outcomes, essentially.
Ms. DiCostanzo.
Thank you, and I'll pass it on to my colleague for the next few minutes.
Which one? Mr. Jessom.
Thank you, Madam Chair. And Ms. Purcell? You received a line of questioning, through the chair, received a line of questioning related to, I guess, subscription of the program, and indicated that there was no cap pertaining to the program. I'm wondering how advertisement, communication, I guess maximizing subscription to the program factors into the greater strategy that's being planned out, to the best of, I guess, either yourself or Ms. Kraglund could jump in here. To the best of your ability, what type of activity do you see taking place to maximize that subscription if there is a gap there? Through the chair.
Ms. Purcell.
So I think across any of our programs, we can always do a better job of making sure we communicate and have the right strategies to reach all the populations that we serve and all the citizens of Nova Scotia. So can we do a better job? Of course, we can always do a better job. And I think working, as Dr. Kraglund has said, working towards a strategy will help us enable not just how we might target those communities, but how we communicate to the groups that we really do know that we need to serve. Right now, really what we do is we work with our partners to make sure the partners have the information on our current programs, and they're the ones who are having those conversations with parents and providers. We also work closely with the health authority, so they have updated information on our programs, and through their public health team can also provide that additional communication in the schools and in the populations that they have outreach to. So they'd be our main mechanisms for communication right now.
Dr. Kraglund, do you want to add to that? Oh, Mr. Jessup.
Thanks so much. What specific role does the Department of Early Childhood Development and Education play as a community partner through the chair?
To who?
Perhaps Ms. Purcell.
Ms. Purcell.
I'm not sure from a direct kind of relationship with our team. I haven't had that outreach right now.
Mr. Jessup.
Okay, fair enough. Specific to, I'm going to shift gears here, specific to the white paper, recommendation 10 suggests mandatory health screening prior to reaching primary, and perhaps both parties may offer some comments. How significant is that, and presently do we have any data related to how many children would be presently subscribing to that type of screening prior to entering the school system?
Who would like to take that? Ms. Grant?
Dr. Kraglund is quite correct. Our collection of data in Canada on oral health is not a good record, and in Nova Scotia, we would follow that. If you look across the public health dental hygienist in Nova Scotia, some regions will say that they are still doing some primary screening when the eye test is, there's only one required screening for primary students, and that's vision exams in Nova Scotia. It's very easy for a dental hygienist to take a flashlight and a mouth mirror or some, wooden sticks and have a look in the mouth and find out whether the child has already received dental care, whether they need dental care, and give them some information on the Children's Oral Health Program, which happened quite regularly at many points. What I understand now is it's not done consistently, and hygienists are not, the few hygienists we do still work in public health are not necessarily invited to those screenings or to do that screening. They're employed in other areas of oral health and other areas of health, I guess. The screening preschool will tell us it might tell us, if we kept good records, on how many people are not accessing the oral health care that MSI would provide, for example. But I believe in 2015, the Cape Breton District School Board did a screening of all grade ones, primaries or ones, and what they found is that a slightly higher percentage than the national average in Canada of those children already had cavities, and some of them had them been to the dentist, and it was slightly higher than average for the number of children who had decay in their mouth. So that's in a very big district in Cape Breton. So again, we're looking at
Order.
pockets.
Time has lapsed, and we will turn it over to the PC Caucus. Mr. LeBlanc for 12 minutes.
Thank you very much, Madam Chair. Thank you all for joining us this afternoon. It's certainly a topic of great discussion that seems to be much bigger, as it was stated, than just at a provincial level, but goes beyond to a national level, and sounds like there needs to be some changes reflected in the Canada Health Act. I'd like to start by stating to the dental hygienist, I can certainly empathize with your profession, as you can see the roles or your possible growth of role or scope of practice similar to mine. I can see that, as you can see the desire to see your scope expand for the benefit of Nova Scotians. What you presented, I guess actually before I go to that, a question for Ms. Lagassé. The last oral health strategy, which was in which year?
Ms. Lagassé.
The province has never had an oral health strategy.
Mr. LeBlanc.
Okay, thank you. So in 2014, the College of Dental Hygienists of Nova Scotia presented this document. When was Dr. Kraglund hired to begin her work on implementing eventually an oral health strategy?
Okay, Ms. Lagassé.
Dr. Kraglund joined the department part-time in March of 2019.
Mr. LeBlanc.
Thank you very much for that. Ms. Grant said earlier that a strategy is certainly a big job, and Dr. Kraglund said we don't, or some organizations are working in silos. So for Ms. Grant, is the job of developing a oral health strategy for Nova Scotia too big of a job for part-time, and I guess would that be too big of a job for a chief medical officer to oversee for Nova Scotia?
Ms. Grant. Okay.
Having never developed a oral health strategy for the province of Nova Scotia, it would be difficult for me to say, but I feel that if they had the right support and services behind them, if they approached it truly with all the players on side, it's possible that the person could be part-time and oversee it, but I would see that it would move along much more quickly if there were someone, whether we call them the Chief Dental Officer in Nova Scotia or another name, but certainly it would have to have a designation, and someone who actually worked in the area of oral health. Oral health has been left out of overall health for so long that sometimes it's difficult to find the right people to marry them back together, and I think that's one of the things that would possibly be a name of an oral health strategy. So might be too big for a part-time person, at least someone who should be working on it, full-time for 6 months. It is a big job.
Mr. LeBlanc.
Thank you very much for that answer. Can somebody explain to what magnitude is oral health an issue for children in Nova Scotia? Just in broad context, we've learned of some of the issues, but from early childhood caries and things like that. But I guess to the longer terms, of chronic conditions or systemic conditions, and how that could negatively impact their life and further go on to causing them further health problems later in life.
Okay, Ms. Hachey.
Unfortunately, I think as has been referred to a few times, one of the challenges in Nova Scotia is lack of data. So our last published data set across the province is from 1995-96 that has been published on. What we do have is subsets of data, as Pat referred to, in terms of the oral health of children in Cape Breton. And we also know that Indigenous children in Cape Breton as well have the highest rate for them to use emergency rooms is for oral pain. So, you know, the outside of that is, as described, I mean, failure to thrive. If you're in pain and potentially have a challenge, if you're at an age where that's difficult to communicate, that affects a whole host of concerns in terms of development, growth, and thriving. So while we don't know what that looks like in terms of across the entire province, the subsets that we do know in terms of use at the IWK, which from a small study that I was involved in, looked to see that the social determinants of health are still very much impacting that population. So from the study that I was involved in, of the people that we looked at that were using the IWK for specifically oral-related disease, not necessarily behavioral problems or medical problems, that still the majority of those people were from rural areas, low socioeconomic backgrounds, and Indigenous populations. And as we know from the Canadian data, on top of those, also new immigrants. And while I haven't had experience working with children, we can say that from the experience that we have of the Dalhousie externships, that yes, of course, they come to Canada with huge challenges, and oral health being one of them that needs to be addressed.
Mr. LeBlanc.
Thank you, Madam Chair, and thank you, Ms. Hachey, for that answer. And I guess that in your comprehensive report that you presented back in 2014, the question was posed earlier regarding which recommendation would be a priority. And I'll ask that in part of my question, but it seems that many of the recommendations sort of would fall under the purview of a chief dental or chief oral health officer in the province. So I guess to let you or give you the opportunity to answer the question, which recommendations would you see as a priority to be implemented in Nova Scotia?
Oh, Ms. Bryan.
I think you're right that the Chief Oral Health Officer would help to develop the oral health strategy that many of us have alluded to. So it does make it very difficult when this is such a multi-pronged approach that is required, and it's a very multifaceted issue that without that comprehensive oral health strategy, it's difficult to make all of those changes. To ask us to pick 1 out of 13 is always very difficult. In terms of increasing the impact and the ability for dental hygienists to be able to provide care to a larger, diverse number of clients or Nova Scotians, one of the things, as we had alluded to earlier, is the fact that they cannot be reimbursed under the MSI program, particularly the Children's Oral Health Program. So that is one barrier that is preventing dental hygienists from improving the oral health for a subset of that population. Was there anything else that any of you wanted to add to those?
Ms. Grant?
I would have to say, trying to meet the needs of the underserved populations in a place where we can actually access them. The people who are not accessing the Children's Oral Health Program now are not going to access it necessarily by putting more leaflets out at the public health center. They need to be met in the communities where they are, and I think that has been demonstrated in many other jurisdictions and programs. We did a screening, the college supported it, but we hired a dental hygienist to run oral health screenings for children with an immunization clinic, and they were for the Syrian refugee children when we received a large number of Syrian refugees in this province. And it was one of the most successful because we were asked to do it by the medical officer who looked after the Syrian refugee people. So I really believe we need to meet some people in the community where they are.
Mr. LeBlanc.
Thank you, Madam Chair, and thank you for that answer. And I think certainly some of these potential solutions could be implemented certainly before an oral health strategy for our province. However, you know, there's sounds like some changes again have to come from a federal level. And I assume that other provinces have strategies, and I guess the federal government has had a strategy. Canada has had its chief dental officer since 2004, which helps promote and educate best practices for oral health. So I guess as is, does it seem that the province, I guess without an oral health strategy, is turning to the federal government for guidance or to seek aspects of their oral health strategy?
Who wants to take that? Ms. Purcell.
So I don't know that I'd capture it as turning to the federal government for that strategy. I think they are also a welcome partner in this. They have some great information online, and so any source of information that's evidence-based and can be an opportunity to educate citizens across the country is terrific. So I wouldn't see it as stepping away from our role at all. The premise when we started the review of our program, so it started with Children's Oral Health Program and a review of that, started with that because it is our largest program. We always knew we needed to have that baseline information of our current program, so that and our other programs, before we moved through the work of a strategy. So it was meant that this would be the foundation of informing a strategy, and part of the work of a strategy was making sure we had resources in-house at the Department of Health through a dental consultant to help build and develop and advise that strategy. I would echo comments made. It wouldn't be work done only by a dental consultant.
Time has lapsed for the PC caucus. We'll turn it over to the NDP caucus for 12 minutes. Ms. Chender.
Thank you, and thank you all for being here today. I want to turn back to the brief conversation we had about billing codes. So my colleague asked about sedation. I've also had the same issue with my child. It's a little bit surprising to me that that's not something that's on the department's radar, because I think it's a huge issue, and we're talking about barriers to access. And I think that those billing codes, notwithstanding the fact that we've heard we don't have a strategy, we have a strategy. I mean, we cover oral health for children up to 14 years of age, and we cover some things and we don't cover other things. And clearly there are challenges in that. And so we hear challenges from both sides. So we hear challenges from, obviously, from an access perspective. So because it's not a universal program, because we're not meeting people where they're at, we hear challenges around getting children to access that program, and the fear that some services will be covered and others won't, and so parents stay away. But we also hear issues from dentists who say it's not all of the services that a child who presents to us needs will be covered, and that puts us in a difficult situation in terms of how to treat that child. And then when we bill MSI, it's a huge administrative burden vis-a-vis working with private insurers. So I would be surprised, actually, if dentists were telling every pregnant mother to bring their child in. That was not my experience in my pregnancies with my 3 children. I actually don't know that that's, I mean, I know that they're being told that. I don't know that it's accurate that they're doing that, though. And so I guess I wonder, can we see a change in that, or do we have to wait 5 years until this strategy is implemented? Like, is there an ongoing review of how those services which are covered for children under 14 are actually covered, and how effective they are?
Ms. Purcell?
So we haven't waited, I guess, for work to continue. We definitely did want to have a review done of our current programs to help inform the direction moving forward. We did negotiate a new agreement with the Nova Scotia Dental Association, and part of that, and it was jointly the proposal to invest in preventative services. So those kind of conversations continue. We meet with them on a regular basis. Part of our new contract is to make sure that we have a touch point and continue to move forward on priority issues. So I would say that, work will continue on our existing programs, and it needs to continue while we do the work to invest in the development and planning of a longer-term strategy. One is not going to happen without the other.
Ms. Gender.
Thank you. And to that end, in terms of ongoing work, we've heard a lot about the lack of data. So I think it's shocking that 1995 is the last complete data set. And so I wonder, especially given that we're at the outset of the development of a robust strategy, are there steps being taken now to collect that data so that it can properly inform that strategy, and that it's based on more than kind of best practices and ideas, but the actual needs of the population?
Ms. Purcell, or?
Okay. So I guess building on Dr. Kraglund and her conversation about an upcoming survey, I don't know what the timing of that is going to be like. We can rely right now on the information that we have, and we can analyze that any number of ways. I think what we're going to have to do in the planning is seeing what other pieces of information we need to bring into that, be it conversations with private insurance, and how we have those conversations to see what information we can get from them to get a more fulsome picture of what's happening in Nova Scotia. Will be part of the building of the background work we need to inform that strategy and the pieces we need, as well as having those conversations with our partners, and they're numerous, to see what other pieces of information that we can get at the community-based level and through other sources to help inform that direction.
Ms. Gender.
Thank you. And maybe just to continue on that line, I think another thing we've heard, and something that we strongly advocate for, would be meeting people where they're at. So we just heard this example of working with the chief medical officer to provide, a large program to arriving refugees. Presumably, the more that these services can be provided in community to broad swaths of people, the more data that can be collected and the more preventative care that's being taken. Are there moves to be expanding that kind of access now?
Ms. Purcell?
I don't know that there is a specific move, although I don't know that we would ever be closed to a conversation about that. I was engaged in the North End Clinic for a long time. I think it is a great example of a community-based healthcare organization and how you service a community in the best way that meets their needs. So I think that is a great example, and we should be looking for more opportunities on how we can do that through a strategy. So a strategy will help to inform where we can go to meet people. It doesn't mean the conversation until we get to that point stops, or that we aren't open to those conversations.
Ms. Gender.
I can't miss the opportunity to just register that when we hear the North End Community Health Clinic as an example, it's both inspiring and deeply frustrating, because that type of clinic is not and will not be funded anywhere else in the province. And so while they do incredible work, we cannot replicate their work as far as we understand anywhere else. And so I guess when you talk about working with partners, that's one partner, and that's amazing for that community. In terms of that kind of access in places like schools, would your partner be the Department of Education, Early Childhood Development? Like, when you say you're open to those conversations, I guess my question is, would you ever initiate those conversations? And if not, then who are the partners who are going to approach you about that?
Dr. Kraglund.
I think that's what the role really of the strategy is that I think there's a lot of good work happening all over the province by so many different organizations, so many different groups, that it really requires some coordination. I think we need to get people together so that we can figure out what's happening and what we can do better. So it's about a coordination about the professional societies and organizations as part of that. It's part of getting the institutions, meaning like the Faculty of Dentistry and all the training institutions, because and I'll pump us up a little bit, but a reason why North End Clinic works so well is that they partnered with the Faculty of Dentistry. And so there's a lot of partnerships that are developed with that. So I think that's maybe what's lacking a lot in the province, is that there's this lack of coordination of getting all the parts together to talk, to see what can be developed moving forward. Because there's some capacity here, there's some capacity there, but it's not, the momentum's lacking. And I think they need that one sort of group to be able to move all that forward. So I think that's what's required. So education needs to be in there, public health needs to be in there. The public health hygienists who are working, we need to be able to maximize what they're doing for oral health. And I don't think that's really being done optimally at the moment. And I think this is the moment that we can get them to optimize to do that, to really be able to do a coordinated effort as a group.
Ms. Gender.
Thank you. And stepping back a little bit, I guess this is probably a question for the acting deputy. Fluoridation was mentioned in the opening statement, so my understanding is that 46% of Nova Scotians have access to water fluoridation. In terms of prevention, the data seems to show this is prevention. And I think, the province certainly has a role to play in terms of flowing through to the municipalities to enable water utilities to provide fluoridation. Is that on the Department of Health's radar? Is that a conversation that's happening?
Ms. Lagassé.
I can answer that.
I'm going to ask Dr. Kraglund to speak to that answer, actually.
Dr. Kraglund.
The nice thing, while I'm employed with the Department of Health and Wellness, I've had lots of conversations with others in government. So I've been talking with those in public health. And so there's talks many places to be able to mobilize people from all across the province to be able to lend support on it. So while I'm in a working group as part of the faculty to make sure that we are getting the information out proactively instead of waiting for information to come up after and trying to defend our stance on water fluoridation, which is really difficult to do. So right now Amherst is one of those communities that's looking at fluoridating. So they have something happening next week. So they're providing some community information sessions so that they can get the support there to have that proper conversation. So I know NSHA is supporting that, even though it's a municipal sort of momentum that's going there.
Ms. Gender, 2 minutes.
Yeah. So I'll just follow up on that. That's good to hear, but I guess I'm talking more about like real dollars for implementation, because municipalities, of course, are a creature of the province. So that's sort of why I directed the question to the deputy, just because I guess, I acknowledge that that's an important role, and I'm glad to see the department playing that role. But if a community decides that they are ready to do that and have the social license to do that, is the department actively thinking about allocating funds that would be necessary for municipalities to be able to do that?
Ms. Lagassé.
Not specifically within the department, but we'd certainly be open to having discussions with other departments, our partners across, our partner departments within government, to have those conversations.
Ms. Gender.
Thank you. I guess in my last couple of minutes, or my last minute, I guess this would be probably directed to you, Dr. Kraglund. In terms of access, again, we had a CCPA report come out today that shows that, as opposed to the 1 in 5 statistic we used last year, we now know that 1 in 4 children in Nova Scotia are living in poverty. 1 in 3 children in Cape Breton are living in poverty. These are the kids whose parents are not taking them to the dentist. How are you addressing that in developing this policy and reducing those barriers to access?
Dr. Kraglund.
So I think that's where it comes in with the oral health strategy, is that it's not just about a treatment, it's also about prevention, it's about the social determinants of health. So it's having those broader conversations with other partners, that if we can have some influence by even just having the conversation, to realize, for them to realize what the impact is of oral health and poor oral health on them, that maybe we can have some policies developed, or at least have some say in policies development that will have some impact overall. So things like food security, for example, Yeah.
Well, that's good timing. We'll turn it over to the Liberal Caucus, Ms. Miller for 12 minutes.
Yeah, thank you, Madam Chair. And I have to say, I think I'm the exception. My children and even my grandchildren have never had to go beyond our family dentist, and has always had great success. And I wonder if I can attribute that a little bit to, and possibly you would too, to the attitude of dentists. Like my kids used to fight to go to the dentist, like it was a competition to see who didn't have any cavities and who had the best teeth, and they couldn't wait to go and just come back and say, hey, I didn't have any, I'm good, you know, whatever, and they were really excited about it. And I just wonder if a little bit of that is it fear? I mean, I don't know why children are going to the dentist and that they're terrified. Why are they terrified? You know, where are they getting that? Is it coming from parents? Is it coming from media? Like, possibly our dental hygienist could speak to that.
Oh, Ms. Major.
So I think that a lot of it can come from parental fear. So if a parent has any sort of past experiences that were not positive, that can translate onto their children. Sometimes kids talk to their friends at school about what their friends' experiences have been, and those aren't always positive either. So I think fear, and also it's a lack of control. Fear comes from a lack of control. So it doesn't matter what the situation is, be it in the dental office or going in for a different type of surgery or just going to a regular dental or a medical appointment for an injection. It's all about loss of control.
Ms. Miller.
Yeah, thank you. And I think I'd have to agree with that. But can you tell me a little bit more about what's going on, the Children's Oral Health Program? Can you tell me about the program, how it works, and what is covered?
Ms. Purcell.
I'm going to try my best not to forget anything. So it is a program that's universally accessible, so it's available to any child in the province with a health card number for Nova Scotia from 0 to 14. It actually goes to the last day of the month of their 15th birthday, to be precise. It covers 1 exam a year, 2 x-rays, fluoride treatments, molar sealants, non-routine extractions, and fillings, and did I forget anything? Prevention service. And a preventative service, thank you.
Ms. Miller.
Now, I noticed you said until 14. How has that age arrived? Was there ever a time that it was more than 14? And, you know, what's the thought process of stopping it at 14 when we recognize children are children till they're a little older than that?
Ms. Purcell.
So since the program's been in place in the early 70s, the age has actually fluctuated a little bit. Over the years, it's gone from 0 to 9. At one time, it was up to 0 to 15, and it's kind of been back and forth, 12, 13, I think, as well, and we're at 14 right now. It varies across the country, so if you look at what's happening across the country, there are different ages as well. When the Oral Health Advisory Group, Phase 1, looked at it, there was no evidence that increasing age actually increased the number of beneficiaries that accessed the program. And so they recommended, and the government supported the recommendation, that the expansion be stopped at that time and that it be part of the work of development of a strategy to look at the evidence of what that age of eligibility should be.
Ms. Miller.
Yeah, thank you for that. And I guess there's been a change in the last year. Apparently, the strategy was expanded in January of 2019. So can you tell me what those changes were?
Ms. Purcell.
So with the new agreement with the Nova Scotia Dental Association, we expanded the availability of fluoride and sealants. So previous to this, they were available, but for a child to access fluoride treatment, they already had to have caries. And to be able to access sealants for their molars, they had to have evidence of kind of deep grooves in their teeth. So that's been removed, and that access since January of last year has expanded.
Ms. Miller.
So just to move on now, what kind of work do the dental hygienists who work for the Nova Scotia Health Authority Public Health do? And I'd like to know what their areas of focus are and where in the province do they work?
Ms. Grant, are you?
actually think that's a question for the province, perhaps.
Okay. Ms. Purcell?
So I'm not going to be familiar with all the details of what these 14 or approximately 14 hygienists do on a day-to-day basis. I know they do provide the dental sealant program. It was a mouth rinse program. It is transitioning next school year to a fluoride varnish program. And so that outreach includes 139 approximate schools that they go into to oversee this. As well, they work with the schools, with daycares, childcare institutions to implement those good nutrition eating habits. I believe there's also some outreach to other communities depending on the need. And as I think I've also heard, it may vary a little bit from zone to zone what the actual work, but those are the highlights.
Ms. Miller.
Okay, and for my last question, so can you tell me what's happened or what's been done by the department over the last 5 years? What advances have been made?
Ms. Purcell.
So 5 years, I'm going to do some math. I think that brings us down to the first oral health review. So Oral Health Advisory Group Phase 1, which was a review of the Children's Oral Health Program. It's completed a review of all the other oral health programs. We've hired a dental consultant part-time. We have expanded, reached agreement with the Nova Scotia Dental Association and expanded specifically treatment preventative services. And we are in the very early stages of developing the plan for an oral health strategy. And if I can add one other thing, we've added a pediatric dentist to the IWK as well as part of their academic funding plan. Sorry to miss that.
Okay, we'll turn it over to Ms. DiCostanzo.
How many minutes do I have, Madam Chair?
You have under 5.
Perfect, thank you. I just wanted, if you can highlight for me that something that confuses me, for example, $120 for a filling, that's what they charge, and the insurance covers an 80. These are just figures that cover. But where do we come up with these figures, and what's the standard in Canada, and why is the insurance paying an 80 when the dentist is charging 120? If you can figure out, if you give us an outline of those figures and who comes out with them, and how does the government deal with that, if you don't mind.
Dr. Kraglund?
So each province or territory comes up with their own fee guide. So fee guides differ from province to province. So Alberta might be very much different than what you see in Ontario, which might be different than what's in Nova Scotia. It is a fee guide. So most dentists will choose to charge whatever it is in the current fee guide, and it changes per year. It doesn't go up by a percentage across the board on every single code, essentially. It might go up by slightly different percentages on different codes. Each insurance plan that comes through the door, and that's where the problem is that we could, as a dental office, deal with hundreds of different insurance plans. And so they're negotiated with the employer and with the companies. And so, for example, when I worked in St. John, Irving was a huge company, and they could have dozens of different plans even within the same company. And so it might not even be the current fee guide that they go on. It could be an older fee guide depending on when negotiations happened. They will negotiate how much percentage they will cover for certain procedures. So if something is a basic procedure, for example, something that would be like an extraction or filling, they might cover 75 or 80% of that. If it's something that's larger, more expensive, like a crown or a denture, they might do it a lesser percentage at which they would cover that. And from there, then the copay would then be the responsibility of the patient to pay to the dental office for the remainder of what would be owed.
Ms. DiCostanzo.
And I believe a couple of the dentists complained to me at one point that, if it's the Green Shield, or for people who are covered through government, if the insurance pays the 80, then there is no coverage for them after that. So the dentist is out with that. Is that correct, or is that not correct?
Ms. Purcell?
So I'll just separate them out. So if I'm only covered through private insurance, so it's for me personally, and my private insurance covers 80%, then I would be responsible to pay the 20. For programs like the Children's Oral Health Program that are in legislation and regulations, we will pay up to the tariff that is set in those regulations. So in some of those cases, it isn't the dental fee that is recommended by the NSDA in Nova Scotia, their guide. We have fee and tariff that might be a bit lower than that. So the dentist is not allowed, not permitted to bill in addition to. So they're not allowed to bill up to what their guide suggests. They have to bill what's in the tariff.
Ms. DiCostanzo.
Thank you. So that there is a standard that the government uses for, for the children, and that's how much it should be. And certain doctors charge more than others. Is that correct? And that's why there's a difference that they will end up with?
Ms. Purcell.
So the dentists that are billing for people that are eligible for our programs, for Children's Oral Health Program, should not be billing above what it is we will pay.
Ms. DiCostanzo.
And just another one is for referrals between doctors. How do you deal with that as well? You know, when a doctor refers to another doctor, do they get paid as well for exams, or do they not?
Dr. Kraglund? Ms. DiCostanzo.
Sorry. So if they go see one dentist and their exam is with them, and then they move to the other, also has to do an exam, do the second dentist get paid as well or not? And how does it work?
Dr. Kraglund.
Yes, they do, particularly when it's a specialist that they send to. So they have to do a separate examination. So the government will pay for both examinations.
Order. Time has lapsed. That wraps up our questioning time. I'll ask our, if there are any closing remarks from our witnesses. Ms. Lagassé.
Thank you, Madam Chair. I would just like to thank the members for having us here today to talk about this important program, and to thank my colleagues, Ms. Purcell and Dr. Kraglund, and our partners at the College of Dental Hygienists for being here today. We hope that we've provided the members with some valuable information, but if you do have any follow-up questions, I'd be happy to speak with any of the members to provide them with further information.
Well, thank you. Any others? No? You may go on your merry way. I'm sure there will be questions by the media when you leave the chamber, and we'll give you a minute or two to leave, and we'll get on with our business part of our meeting. We would love to have your closing remarks. Ms. Bryan.
My apologies. I said I didn't have written ones in advance. I was going to do it based on the feedback that we heard today, so that's probably where the confusion. Just wanted to start off by thanking you very much to inviting us here today to continue with this dialogue. We appreciate the opportunity to provide our feedback to your very insightful questions. I think it is apparent to all of us that all of you are very passionate about improving the oral health care for all Nova Scotians. For many Nova Scotians, we will say that the oral health system appears to be working well as the rate of oral disease continues to decline across Canada. But a more intentional approach is needed to reduce the inequalities that we've outlined today regarding the populations of children who are experiencing that heavier burden of oral disease. We feel that it's time to put the mouth back into the body and help decrease the burden of oral disease on both the individual and the already overtaxed health system. Prevention at the right time with the right resources will help to reduce this burden. This includes implementing direct delivery services via school and community-based programs, offering integrated approaches for the earliest intervention possible, using oral health care providers to their full scope of practice, and implementing regulations that allow for financial reimbursement of dental hygienists as providers. all of the discussions that we have had today, none of these options or innovative solutions that we're offering are an expansion of scope. They're merely using dental hygienists to their full scope of practice, what is already in existence. And we would encourage all of you to access some of your most important resources to assist with these solutions, the oral health care providers in your communities, including dental hygienists. I would encourage you to seek feedback from those providers in all settings, those in public health, private dental and dental hygiene practice, as well as others who are providing services in other community settings. These individuals have their ears to the ground and they know the specific needs for these communities as well as potential solutions. The CDHNS will continue to work closely with stakeholders, including government, Nova Scotia's professional education, and healthcare sectors to address the challenges that we've identified and further the integration of oral health and dental hygienists into the primary healthcare system into Nova Scotia. I believe that working together we can implement more innovative solutions to help resolve these issues in Nova Scotia. Thank you again for your time.
And thank you, Ms. Bryan. You may leave the chamber, and we're just going to have a very short business meeting. Okay, we will turn to the business portion of our meeting today, and we have from the Department of Health and Wellness updated organizational charts. You would have received them by email. They are very long, and so I directed the clerk myself not to print them off for everybody. If anyone would like them, I suggest that you print them off yourself or use your electronic devices to peruse them. You have a printed copy in front of you from the Deputy Lagassé, which includes a request. In order to ensure that we are providing useful information to the committee, the Department of Health and Wellness would like to propose that going forward, information on our organizational structure and staffing be provided for the executive leadership team and staff down to the director level. Please let us know if this will satisfy the interests of the committee. If more information is required. I think that's because of the number of pages it requires. So we're asking for suggestions. Are we in agreement with that, or is that an issue? Ms. Adams.
Thank you. So I was the one who suggested that we get this update. I'm not quite sure I understand why we wouldn't continue to get the update for all the departments, because I'm assuming they are keeping those charts up to date. So I'm not sure I understand why we would want to exclude them. I certainly find them all helpful. So I don't know how big a deal it is to update them on all the way down the list. So my recommendation is that we keep it as is, which is to request that they update all of the hierarchy charts that they've been doing so far.
On a quarterly basis. Any other comments? Are we in agreement to continue with this practice? Agreed? We're agreed. So if you can pass that along. Thank you to our clerk, who I did not introduce for our meeting, Judy Kavanaugh, and our ledge counsel, Mr. Hebb. I left you out of our introductions at the beginning of the meeting. My apologies for that. Also, the Nova Scotia Health Authority updated their organizational chart. It's on the back. It's more, it's a one-sheeter. And the clerk printed it off because it was one sheet only. Okay, our next meeting is Tuesday, February 11th, 2020. Our topic will be Youth Mental Health Outreach Program, Cape Breton base. Is that what it means? Okay. Witness is Samantha Hodder, Senior Director in Mental Health and Addictions in the Nova Scotia Health Authority. Here, no further business. I adjourn this meeting.